Hi, I'm Ross Camidge. I am the Director of Thoracic Oncology at the University of Colorado. One of the amazing things about treating patients with advanced ALK-positive lung cancer is that they can stay alive for years now. In our own center, the median overall survival was over 8 years, and that's only getting longer. So sometimes it's about doing ALK TKI followed by ALK TKI followed by ALK TKI. And that strategy works, providing the cancer remains addicted just to ALK, and all it does is just turns back on that signaling cascade through maybe another ALK mutation each time. But eventually, that's going to fail as a strategy. Now, it's going to fail for a couple of reasons. So it may fail because when you're building sequential ALK inhibitors, each time there's a kind of hole in their coverage and one mutation manages to get through, that's the backbone on which the next mechanism of acquired resistance is built. So you start to get compound mutations, more than one mutation in the same gene. Those are very difficult to treat. None of the current next generation inhibitors work on compound mutations, but people are developing drugs. So there's a couple of companies, one is called Nuvalent, another is called Turning Point, who are developing drugs that work on some of those common compound mutations. They're a relatively small niche population, but if you know what it is, if you find them, you're going to be drugs for that in the future. Perhaps the biggest elephant in the room, I think, is when there are second drivers. So there's no on-target resistance mutation, and then some other pathways come in. Just a word of caution. The absence of an ALK mutation and something's progressing is clear evidence that there's probably a second driver. But one area where you can get caught out is if you find a resistance mutation and you're assuming that that is the mechanism of acquired resistance. That is true if that's the first time you biopsy the patient after their initial therapy. But if you biopsy them after about their third ALK TKI and you see that resistance mutation, you don't actually know that that's not the carry through the mechanism of resistance from their first line, and what they've actually got is a second driver built on top of that. So just a word of caution that if you don't find an ALK mutation, it's more likely to be a second driver. If you do, yes, it's more likely to be an on-target resistance, but engage your brain and just say, is that reported as the mechanism of resistance to the last drug they've been on, or should it have been sensitive? And if it should have been sensitive and it's growing through, it's because it's got a friend dragging it up at the same time. Now, what do you do there? If you can find the second driver, you can rationally add in another therapy. Or if you don't find anything or you don't have facilities to do that, you keep them on the last well-tolerated ALK inhibitor, and then it's about adding in chemotherapy. Okay, a word about this. If you're going to get to the point where you're going to give chemotherapy, it's got to be pemetrexed based. We've known since 2011 that the gene rearrangement diseases, particularly ALK, ROS1, and also RET, are hypersensitive in a subset to pemetrexed based chemotherapy. We still don't really understand why, but therefore it's not carboplatin Taxol, carboplatin gemcitabine. You really got to go for the pemetrexed if you can. I also said add it in. Now, I can't prove this, but this is my prejudice. The ALK is still suppressing some of the cancer, and in particular, it's probably suppressing a lot of the cancer in the brain. So taking it away, just so you can go into chemoimmunotherapy and not have the interaction between immunotherapy and the TKI, makes me feel very worried. So I tend to forget about the immunotherapy. There's very little data that immunotherapy does anything in ALK, and I add in just carboplatin and pemetrexed and keep that TKI going. If that doesn't work, it's about staying on the ALK TKI and adding in different cytotoxics. I'll go to Taxol, I'll go to gemcitabine, I'll go to irinotecan. That's how you keep these patients alive for a very long time, and also the creative use of local radiotherapy for oligoprogression. You can have patients who will be alive for a decade in a few years' time, I will predict, with advanced ALK-positive lung cancer.